Okay, good evening, all the students, and I welcome you for this MD lecture. And the topic that I'm going to discuss in next 30-40 minutes is about approach to lymphoma and its management. Since this is a PAN MD topic lecture, so which will include first year student and final year as well, I am going to give you a broad overview and then touch upon some specific points. As far as therapy is concerned, we are only going to touch the frontline therapy initially, because if you go deeper into it, then each subtype of lymphoma is a topic in itself. So with this, I think let's make a opening. Yeah. So I think the first question, which is a very, very genuine question for a first year newly entered person in the MD, what is a lymphoma? In single sentence, how can you define lymphoma? Lymphoma is a disease which is, should I say, suffering from heterogeneity. There are not many disorders in the world in which you can find this amount of heterogeneity. We have, some sarcomas are there, other disorders are there, but this much heterogeneity within a disease. So there are around 70 to 80 different types of disease within this subset of lymphoma, which is very rare. So therefore, to give a single common definition for lymphoma is difficult. If I would like to summarize that, we can say that lymphoma is nothing. Lymphoma are malignancies of immune system. This is the best single definition I can think of regarding lymphoma. So whenever you think of lymphoma, if you remember this definition, you can just immediately relate that this person is undergoing or carrying with himself or herself a severe amount of immune dysregulation, which has led to formation of this malignancy. So the difference between solid tumor and hematological malignancies is this, that solid tumors are anatomically well defined. But diseases like leukemia and lymphoma, they are not that well defined. Therefore, they can have a protean manifestation and become slightly difficult to understand and decipher. I will try to make the job of understanding this complex disorder easy, and let's move on. So we have seen that lymphoma are malignancy of immune system. The second question, natural question for especially a newly inducted person will be, what comprises immune system? There's a natural question. If you just go back to your third year of MBBS, you all have read in the Robbins and Pathology books, immune system is nothing but a composition of organs and processes of the body that provide resistance to various infection as well as toxins. This is a theoretical definition. In practice, what is immune system? Immune system is nothing but a constellation of mutual interaction and function of organs like thymus, bone marrow, last but never the least, lymph nodes. So it is the interplay between the function of lymph node, bone marrow, and thymus, because all of these sites are the sites of immune response, primary or secondary. So therefore, since lymphoma are nothing but the malignancy of immune system, these are the major sites of affection. Whenever there is lymphoma, it is likely that either the lymph node or the bone marrow or thymus in various proportion and distribution be involved. So if you can see that this diagram depicts nothing but the immune system. We talked about thymus, we talked about bone marrow, we talked about various lymph nodes. Apart from that, we have also some other organs like spleen, Peyer's patches. Peyer's patches are there in the GIT. Similarly, we have bronchial ball tissue. Then we have adenoids, tonsil, which are palatine tonsil as well as adenoids. And we have some lymphoid tissue in the lacrimal glands, salivary glands, and some other parts of the body. So in this picture, you can just summarize or envisage where all lymphoma can present, because it can involve the marrow, it can involve the blood, it can go to virtually any part of the body. However, lymph node, spleen, thymus, thyroid to some extent, tonsil, adenoids, and the Peyer's patches, the GIT. These are the common sites, and these are the common sites of origin of a lymphoma. So this is the overview to understand about what is lymphoma, how does it manifest. Now let us move further slightly towards the epidemiology. Now, if I ask you, what is the commonest malignancy and what is the commonest hematological malignancy? So anybody can answer before I show this? Exam going batch, I invite, let's make it interactive. Okay, all right. So I think listeners are very shy. So this is the latest Globocon data. Globocon is a US body which keeps track of lympho cancer incidence across the world, and you can see that lung cancer is leading the race by a far margin. Lungs and prostate cancer. This is for males. I just want to highlight here. This is for males. This side is for developing country incidences, and this side for developed countries. So you can see lung and prostate cancer and colorectal, three top cancers are there. But the second question which I ask all of you is, which is the commonest hematological malignancy? The answer is, it is lymphoma. Lymphoma are more slightly, they beat leukemia by a very narrow margin. If you see over here, so non-Hodgkin's lymphoma, they are ninth in the list of all tumors. However, amongst the hematological malignancies, they are number one. So this can be a common MCQ or simple quiz question, which is the commonest type of hematological malignancy. Answer is non-Hodgkin lymphoma. Now, if I would like to tell you that this is only non-Hodgkin lymphoma. If you add Hodgkin lymphoma, it will be clearly the commonest malignancy if you just take lymphoma. So this is the latest Globocon data published this year only, and you can see this slide can be very useful for all of you for normal understanding of those interested in oncology. It is very, very important. Otherwise, also as a medical personnel. Now, one thing I would like to draw your attention to is that you see the cancer incidence in developed countries is far, far more than developing countries. I would like to tell you, this does not reflect the true story of the biology. This has a lot to do with underreporting and underdiagnosis in developing countries. Many countries like in Asia and Africa, they do not have means to diagnose cancer in time. Even if they can diagnose, they don't have the system to report it. Our country, India, is somewhere in the middle of the two. We have a national cancer registry program, although this is not the best of one, not a very robust one, but it is available and we are improving upon that. So because of better reporting and capturing of all diagnosed cases, we can find that incidences are high. Apart from that, the second reason of having these high cancer incidences is longevity. The average life expectancy in the developed countries like USA, Japan, Canada, Europe, Western Europe is very high. So people live long enough for a malignancy to develop within their body. It is a natural process. So these are the two reasons. And third remains the habits, smoking, alcohol, and, in light skin people, sun exposure. All of those things are there. So this is the overall understanding of epidemiology of the cancer, which I am sharing with you. This is a graph of female individual, and you can see in females, breast cancer is very, very high by far, a huge margin. The second closest is cervix, and you can see here in cervical cancer, it is the developing countries where it is more common for obvious reason, because of the higher incidence of human papillomavirus, because of poor sexual and genital hygiene. Incidence of human papillomavirus related cervical dysplasia is very common, which ultimately is a precursor for cervical cancer. And then against the same thing, and here you can see that non-Hodgkin lymphoma and leukemia, they are almost at par with each other. But if you combine non-Hodgkin and Hodgkin lymphoma, lymphoma again will be the commonest malignancy of hematopoietic system. So coming to from the global perspective, let's come to India. This is some Indian data. So highest report of lymphoma, highest report of incidence of lymphoma comes from the Western countries, which comprise especially the Caucasian, the white Caucasian population has highest incidence of lymphoma. So if you see Northern America, not the Southern America, Europe and Australia, they have the highest incidence. And the least incidence of lymphoma is from Eastern Asia. So India does not fall in Eastern Asia. India is a part of Southern Asia. So you can see there is a geographical dichotomy between the incidence of lymphoma in various parts of the world. So where do we stand as a country in India? So India falls somewhere in between, in the middle. So let's go back to this slide again. So this number, what is this number? This is number of cases per 100,000 individual. 1 lakh population में कितने मरीज हैं? So you can see non-Hodgkin lymphoma in developed countries is around 8. 7.9, and in low, medium, or developing countries, it is, where is it? It is 4. Okay, this is the incidence, this is mortality. If you see Indian data, this is the Indian data which says the same thing. 4 cases of lymphoma for every 1 lakh people, normal population. So if we take this estimate and try to have a projection or ballpark figure for 1.3 to 1.4 crore people in our country, we are likely to see 50,000 new cases of lymphoma every year. This is like a time bomb. In fact, the whole of the America and Europe together does not see this kind of cases. So this is a big challenge for all of us. So now taking you back to some pathology, because in oncology, pathology is the holy grail, and without good pathology, the further practice of optimal care is not possible. We know lymph nodes are our police stations. They are the centers of first immune surveillance, where we have lymph node in all the parts of the body, and they are the first response sites. Okay, they mount first immune response apart from innate immunity, and they process exogenous antigen, which enters from whatever means, and then they handle it. Now, I just want to show you here. So this is the area, and this is the axillary lymph node group. It drains from the anti-HS wall as well as the whole upper limb. So whatever injury is going to be there, any innocuous or any harmful antigen which enters through the vessel or the lymph reaches here, and here it is handled, and in most cases, it is killed there. Sometimes it surpasses this immune surveillance checkpoint, then it leads to much more disease. So this is the overview of the lymphoid system and immune system, and the incidence of lymphoma you understood. Now with this, I am going to take you on the deeper cellular aspect. This is the morphological aspect, anatomical aspect, clinical examination aspect. Let's go to the cellular aspect. Whatever I spoke is shown better in this cartoon. You can see this is a cross section of lymph node, and there are afferent and efferent vessels. So like various cells, various hematopoietic and lymphoid cell, lymphocyte, plasma cell, they keep traversing through the lymph node. They come in, they go out. Along with them comes antigen. The antigen gets presented within the body of lymph node, and after the presentation of antigen, the quiet cells become active. The quiet immune cells, especially the lymphocytes, so to speak, both B and T, they get activated, and now these activated lymphocytes through the sinus of lymph node go to the afferent vessel and to the blood. So this is what it is. There is a very nice quiz question which we are always confused about, that how many lymph nodes are there in human body. Most of us don't have any idea. When I was in MD, I really do not have any idea how many lymph nodes are there. But there is a reference. There is a referral from Gray's Anatomy. An average individual adult, human adult, has around 450 to 500 lymph nodes inside the body, divided at various sites. So this can be a common quiz question, nothing to do with lymphoma, but I think this understanding is very much needed. Now I'll skip this. I'll give you a peep into the history of lymphoma, and like any other history, it is also rife with various types of classification and all. You can have a look at it later. The only point to be noted from here is currently we use WHO classification, and the latest version is 2016, 2017, which came very recently. Right. So just a minute. Yeah, you can see. So this is the latest version, and which is very recent. Okay. Coming to etiology of lymphoma, this is a common question. The people who are heavy smoker, you can see that the second common tumor you see in your practice in MD is lung cancer, and there is a very beautiful causal relationship with smoking and tobacco consumption and lung cancer. No such thing exists in lymphoma, and majority of the patients have lymphoma as an idiopathic etiology. There is no specific pathogen. However, there are specific conditions which can predispose an individual for developing lymphoma, and you can broadly divide them into 4 categories. The commonest one is, I would say, infection again, and the viruses and bacteria which are associated with some specific lymphoma are Epstein-Barr virus, HIV, H. pylori, HTLV is human T-cell leukemia lymphoma virus, hepatitis C virus, and HHV8. Similarly, some primary or secondary acquired immunodeficiency condition like ataxia telangiectasia, Wiskott-Aldrich, AIDS, which is acquired, and post-transplant patient. You all have seen patient of PTLD in your nephro posting. So these are the condition. Autoimmune disorders, for example, Hashimoto thyroiditis, Sjogren syndrome, celiac disease, and there are listed more. There are a few major ones. So these are these conditions predispose any individual to develop lymphoma in future, and other which are poor yet not well defined. Some people have related tobacco with lymphoma as well as recreational drugs like contrabands. And there is some association between high intake of meat and dietary fats. And this may be one of the reasons that why developed countries, because they consume high amount of fat and meat, they might have higher incidence of lymphoma. However, the bottom line is it is multifactorial why Western people have more lymphoma. Now, because internal medicine deals with a lot of infection, it is important for me to have this slide. Now, this shows various infection agents and their association with various kinds of lymphoma. So, as I told you, Epstein-Barr virus is the commonest virus causing lymphoma, and it is associated with these 5 different kinds of lymphoma. The most important lymphoma I would like to tell about EBV is Burkitt's lymphoma and PTLD. The patient of various or solid organ transplant have high risk of developing PTLD because of overactivity, unchecked overactivity of Epstein-Barr virus. If we talk of solid organ transplant, the maximum risk is in the recipient of GIT, pancreas and small intestinal transplant. The next is in the hepatic transplant recipient, and the third one is patient who are renal transplant. But we see more PTLD in renal transplant patients because the number of renal transplant is high numerically. Apart from that, you can see HIV, which is the second most common viral infection prevalent in our country, is like diffuse large B-cell lymphoma, Burkitt's lymphoma. They are AIDS-defining lymphoma. And similarly, we have other illnesses. Human herpes virus 8 is a common quiz question people ask. Primary effusion lymphoma and multicentric Castleman's disease. Today is Monday, and today itself we saw one patient of Castleman's disease. However, it was unicentric. A young girl came to our clinic. So these are the you should know for the theory's sake and important aspects of the knowledge. Yeah. So this is a cut section of lymphoma. Just remember your CPC. So this is a lymph node, and showing these areas are germinal centers. Follicle, and follicle contains this germinal center. So if you see carefully here, you can see a lighter area, and this is a darker area. The darker area is actually a mantle zone. From here arises mantle zone lymphoma, mantle cell lymphoma, and this is germinal center, which is shown better in the form of a cartoon here. Now, if we just open up this germinal center, and so this is going to be highlighted in the next slide. So this is the whole germinal center. You can see lymphocytes are arranged beautifully. The germinal center is just highlighted. The cells which are there in this mantle zone is like a protection. These cells give rise to a kind of lymphoma which is called mantle cell lymphoma. You know, sometimes you may wonder, why do we call it mantle cell? Why do we call it marginal zone lymphoma? The answer lies in this slide. The lymphoma which arises from cell which rest in mantle zone is mantle cell lymphoma. Outside the mantle zone is marginal zone, and the cells which rest in the marginal zone, they give rise to marginal zone lymphoma. It may be slightly complex for a newly first-year person because you have not seen many CPCs and pathology slides, but try to envisage a structure where cells are compartmentalized in different parts of a lymph node, and they are giving rise to different kinds of lymphoma. This concept will be better explained in this slide. Here you can see the elongated lymphoid follicle, and it is over here, and it shows the journey of a lymphocyte from undeveloped, which is naive, to a maturest form, which is memory B cell or plasma cell. So you can see in the initial part of the germinal center, lymphocytes are only there. Antigen can come from whatever way possible. There will be an exposure of antigen. After this exposure, there will be activation. This activation takes place in the germinal center. And after the activation, these cells are primed to produce antibody or memory B cells against that particular antigen. And from the germinal center, they are released. So this is very important. This concept is very important for you to understand, because cell or lymphocyte at each stage can give rise to different kind of malignancy. Like in mantle zone, they produce mantle cell lymphoma. If it is a plasma cell, multiple myeloma. If it is memory B cell, they produce either CLL or hairy cell leukemia. I think there is another lecture lined up for CLPD. We will focus on this in that lecture. And for germinal center, which are the main crux today, these are the activated lymphocytes, and they give rise to most commonly DLBCL, the commonest lymphoma, Burkitt's, and follicular lymphoma also arises from these mature cells. Right. So coming to the classification of lymphoma, so there is one clinical classification and one pathologic classification. I have made it very simple. Clinical has only two types. Pathologic classification has only two types. Pathological, we know B cell lymphoma or T cell lymphoma. T cell also contain NK cell lymphoma. So B cell and T cell, that's it. For clinical classification, it is either aggressive lymphoma or indolent lymphoma. Let me tell you, the clinical classification has nothing to do with either imaging or either the cell or pathology. It is just clinical presentation. Let us have a look on that. So this is aggressive and this is indolent. Let's take indolent first. Indolent lymphoma, as the name, is an English word. It's not a medical word or any other special Latin word. These are English words. Indolent is slow, tardy pace. That's all. So if there is a patient who is having growth of lymph node over a slower pace, by and large, patient remain asymptomatic. And after that, they just present with, because of development of a lymph node, they are not having any organ dysfunction. These kind of lymphoma are called indolent lymphoma, and the commonest example is follicular lymphoma, marginal zone lymphoma, and SLL is a small lymphocytic lymphoma also do fall in this category. Aggressive, as the name suggests, they are very rapidly growing. They make a patient very sick quickly. If left untreated, they can kill the patient in the span of weeks to months. So you can further classify like very rapid, only two lymphoma, lymphoblastic and Burkitt's lymphoma. If you do not treat them, patient can die within days to weeks. And if it is a fast progressing lymphoma, but less than these two, these lymphoma are DLBCL, PTCL is mainly peripheral T cell lymphoma, mantle cell, and anaplastic large cell lymphoma. These are the few examples if you want to understand deeper. So just remember broadly that we are talking about aggressive and indolent clinically. Right. Now coming to the pathology classification, as I told you in the previous slide, B cell and T cell. Now it is very interesting here that around, if you are seeing a patient of lymphoma and I ask you which lymphoma it can be, you can safely say it is B cell lymphoma because you are likely to be right 80 to 85% of the time. B cell lymphoma are the commonest, around like every 4 in 5 cases of lymphoma will be B cell lymphoma, 80 to 85%, and T cell are the remaining. Further, if we go deeper into it, those who are interested, they can refer to this WHO classification. There is a long list. Let me tell you, in today's era, 2022, there is no need to remember all of these subtypes. If you practice them, you will remember it. However, what you need to know is that B and T cell, B cell is more common, and amongst the B cell, DLBCL and Burkitt's and follicular lymphoma, these are the more aggressive and common ones. Okay, all right. With this overview, any question till now? Anybody? I don't know whether where to see chat in this. You can unmute and ask also. I will take a pause. Dr. Lenta, is there a function of chat over here? You can put in your question. All right. So now moving to DLBCL. As I told you, DLBCL is the commonest type of lymphoma. And as the name suggests, you can see DLBCL arises from the germinal center. This is the holy grail of lymphoma. This is the most active. This is a site where you will find most active lymphocytes. So these are the large centroblasts which give rise to DLBCL. And you will see why do we call it DLBCL. It is because all of the component of the name are in this slide. These stand for diffuse. You can see there's a diffuse pattern of lymph node. This is a cut section of lymph node, which is absolutely like a clean carpet. Now, next word is large. You can see here, these cells are large malignancies. This is the normal lymphocyte. If you see here, they are small RBC-like cells. These are with the chromatin, which is very dense. But these are the malignant lymphoma cell. You can see they are very, very large, opened up chromatin and large nucleoli. So therefore, diffuse, large. Next word is B cell. So these are CD20 positive cells, tightly packed. That's why B cell. And the last word in DLBCL is lymphoma. So each and every word in the name DLBCL is self-explanatory. With this introduction, next is follicular lymphoma. Again, the name is self-explanatory. Follicular is because of follicular pattern. You see over here, there are two panels. Number one, this is a follicular hyperplasia. Now, for example, we all have had some kind of injury in the hand, and after that, you have seen lymph node enlarge. Maybe we have tonsillitis and cervical lymph node enlarge. That is follicular hyperplasia. So you can see the follicles are still confined to the cortex where they should be. They are enlarged. They are very well defined and well shaped. On the other hand, follicular lymphoma on this panel is a malignancy. Here, all the lymph nodes, they have all the follicles, they have replaced entire lymph node altogether. There is no differentiation. They are irregular in size. They are very poorly developed. So this is the difference between a follicular lymphoma. Because of this particular follicular pattern, we have follicular lymphoma. All follicular lymphoma are B cell, right? Third common one is mantle cell lymphoma. I told you, if you want to remember one thing from this slide, it is cyclin D1 positivity. There is no malignancy known to human being which is cyclin D1 positive. It is very much specific. All cyclin D1 positive lymphoma will be mantle cell lymphoma, but there can be subset of mantle cell lymphoma which can be cyclin D1 negative. So therefore, cyclin D1 is highly specific, not sensitive. I hope you understand the concept of sensitivity and specificity. The other morphological feature of mantle cell lymphoma is this indented nucleus. So if you do a FNAC and if there is a smart cytopathologist, they can just find out these kind of immature aggressive cells with this nuclear indentation you can see in almost every cell, and they can suspect it is cyclin D1 positive mantle cell lymphoma. They can order a cyclin D1, and if positive, it can be diagnosed. Okay, so one thing which is very intriguing. Now, all of the students, you may go to different branches. Some may go to pulmonary medicine, some may go to gastro and all, neuro. It is likely that you will not see systemic nodal lymphoma. But marginal zone lymphoma is one thing which you need to be aware of, because this can involve virtually any part of the body, because mucosa-associated lymphoid tissue MALT can be present anywhere, from skin to GIT to lung to the orbit. It can be there. All of these sites. So this lymphoma can be divided in major, nodal, extra-nodal, and splenic, three major subtypes. Just to give you some idea, nodal will primarily involve marginal zone of the lymph node. So patient will just present as nodal lymph nodal enlargement, nothing more. This is the most exciting one. Patient can have gastric lymphoma, which is related to H. pylori. Patient can have intestinal obstruction, intussusception, or malabsorption because of the GIT pairs patches are involved. If it is in the bronchus, then it can lead to obstruction, collapse, consolidation, effusion. If it is in the orbit, like lacrimal glands, it can give rise to large orbital mass, proptosis also. Salivary gland, patient can present with a Sjogren-like situation. So this is very exciting and very protean and difficult to pick up. Thyroid is one side. Patient can present just like a goiter. However, people may take it as if the patient is coming from Himalayan Tarai region, people can just treat as a goiter, but in fact, it is lymphoma. The last is splenic marginal zone lymphoma, and they are very peculiar because in majority of the patient, the disease will be confined to only spleen or the bone marrow. Now, we have talked a lot about B-cell lymphoma because B-cell lymphoma are very common, the commonest one. For T-cell lymphoma, in the interest of time, I am just giving you name. The commonest T-cell lymphoma is number one, peripheral T-cell lymphoma. The other that you should know is anaplastic large cell lymphoma, AITL or angioimmunoblastic T-cell lymphoma, and cutaneous T-cell lymphoma. Cutaneous T-cell lymphoma is nothing but the other name of mycosis fungoides. All right. So this is T-cell lymphoma. Now coming to a common thing which many of you who are posted with us understand, staging for lymphoma. So one bottom line is, both PET-CT or CT neck, chest, and abdomen are acceptable. If you have PET-CT, PET-CT is preferable because as a functional imaging, it gives a better understanding and it is more reproducible. Only CT is largely observer dependent, so therefore PET-CT is preferred. However, if you do not have access to PET-CT, no problem. CT neck, chest, and abdomen is completely acceptable as a staging modality. This is very common. I think all of you know it. Stage 1 is only one side of diaphragm, either in the lymph node or in extra lymphatic organ. Stage 2, at two different sites which are anatomically different. They should not be contiguous, but they should be on the one side of diaphragm. It is stage 2. Stage 3 is across the diaphragm, multiple site. Stage 4 is specific organs like bone marrow, liver, brain, or disseminated multiple extranodal site. It makes stage 4. I want all of you to pay special attention to these suffixes, which are very, very important, like A, B, X, and E. I must revise it. B stand for presence of B symptoms. A means nothing actually. A is a negative word. A means absence of B symptom. Therefore, it is called A. B, if any of the three symptoms defined by unexplained fever more than 38, wrenching night sweats, and unexplained loss of weight more than 10% in last 6 months or 5% in 1 month. So these are B symptoms. Bulky disease is defined as more than 10 centimeter maximum horizontal tumor diameter, and E is involvement of extranodal site, which is contiguous, like a lymph node is there, and along with that, extranodal site is involved. So it is very common for anybody to get confused, but one must understand the suffix, right? Workup. How will you work up? Needless to say, history and B symptom assessment and detailed physical examination, these are invaluable. You have to have adequate lymph node biopsy. Here I have written adequate and biopsy both, because FNAC now, modern cytology techniques are improving. We have cell block, we have flow cytometry, things are changing. But if you ask, still the mainstay of diagnosis of lymphoma is lymph node biopsy or affected organ biopsy. So one must try to get a biopsy wherever possible. Other standard workup like hemogram with ESR, biochemistry, detailed workup. And in patients who are having suspected CNS lesions, you must do a CSF examination. And these are the other indication of doing CSF. LDH and vitamin D3. LDH and vitamin D3 both are prognostic for future outcome in patients with lymphoma. High LDH and low vitamin D, they both were associated with poor survival in these patients. So try to do vitamin D and LDH in all the patients. These parameters will help you to calculate International Prognostic Index, which is also known as IPI. Now, we have talked about a workup of this patient. So we have already talked about PET CT and bone marrow biopsy. One common question that is asked nowadays, do we need to do bone marrow biopsy in all the patient of lymphoma for staging? The answer is now no. If the patient is having early stage lymphoma and PET scan shows that the bone marrow is clear, then you need not to do a bone marrow biopsy. You can omit it. These are the other investigation that you do usually, all the viral markers, 2D echo, pregnancy test, or in the women of reproductive potential. And sperm banking should be offered for patient whose family is not complete. Coming to the last part of the presentation is treatment synopsis. I am not going to go deeper into various regimens. They are very complex and you won't be able to remember them. I'm going to just introduce you the therapy. For B-cell lymphoma, we have R-CHOP therapy. R-CHOP therapy has been almost the undisputed king of management of lymphoma. It used to be CHOP therapy for last 30-40 years, but rituximab is a valuable addition in last 18 years. For last 18 years, this is ruling the roost. In T-cell lymphoma, we do not use rituximab because it is anti-CD20, which is missing from T cells. So it is a CHOP chemotherapy. What do they stand for? C stand for cyclophosphamide. H is doxorubicin, but it is written H because the name is hydroxydonorubicin. O is vincristine, but in the older times, maybe in 1950s, 60s, when the drug was discovered, it was called Oncovin. So it is still continuing from that era. And P stands for humble prednisolone. As a doctor, as an MD resident who are studying in 2022, you must understand the mechanism of action of this fascinating drug rituximab. It has three kinds of action. The number one, the most potent one is ADCC, and all of you know it is antibody-dependent cell cytotoxicity. So you can see that this rituximab is going and binding on CD20 somewhere here on a B cell, and then on the rituximab molecule, the cell which deliver ADCC like cytotoxic T cell macrophages, they come and they kill it. The second mechanism is complement fixation. So you can see this FC portion of rituximab, it fixes complement and makes membrane attack complexes. All of you know about it, and thus it kills a cancer cell. The third one is a direct apoptotic effect. If rituximab binds to a B malignant lymphocyte, it undergo apoptosis, and hence in these three manners, this drug kills. So therefore, it is such a beauty because it has three different mechanisms of action. So if a tumor cell develops some resistance against, say, one action, there are always other actions to kill a tumor cell. So therefore, it was a very, very nice value addition to the armamentarium of lymphoma doctors to kill this malignancy. You can see the impact of rituximab. So this is the benefit. This is a survival with CHOP. You can see over here, at 5 years, the survival used to be around 30%. After just addition of rituximab, it is now around 50% or more in many subtypes. Okay, so you learned about CHOP, but how many CHOP, how far, and how frequent? The answer is, if it is early stage, you can just give 3 or 4 cycles of CHOP and give radiotherapy to the involved site. Now, because it is early stage, lymphoma is likely to be confined to a particular region. So therefore, giving radiotherapy is practical. This is one way. The other way is you complete 6 cycles of R-CHOP chemotherapy. If the patient is in remission, that's it, no treatment is needed. But if there is some residual disease here and there, then you may give local RT or radiotherapy to that area. Now, if it is advanced stage lymphoma, which is defined by stage 2 with bulky disease or B symptom, or any stage 3 and 4, then you have to give around 6 cycles of R-CHOP chemotherapy. In the previous years, not far behind, just 10 years ago, people used to give 8 chemotherapy cycles, but now the evidence is emerging that giving additional giving 8 cycles does not add much value, rather it adds to toxicity. Similarly, if after this chemotherapy there is a solitary site, you can give radiotherapy. So this is in a nutshell about management of DLBCL, and DLBCL is representative of most of the lymphomas. So pretty much these principles apply for most of the lymphomas. Right, so this is DLBCL. The next one is indolent lymphoma. The major we are going to discuss more about this in CLPD in the next lecture, but just to give you an overview, indolent lymphoma, as I told you in the beginning, they are really slow growing. If they are really slow growing, there are instances that they do not impair with the organ function, and your oncologist may decide against giving chemotherapy because in certain situation in these indolent lymphoma, giving chemotherapy can be more toxic rather than leaving the lymphoma alone. So therefore, it is contrary to common belief. This is one situation where even after a clear diagnosis of a tumor, the doctor may not treat a patient immediately, right? So these are the indications which we will discuss in the next lecture. Now, this was the overview of non-Hodgkin lymphoma. Hodgkin lymphoma is a smaller subset of whole lymphoma disease spectrum. Now, I will tell you, for every 4 non-Hodgkin lymphoma, there is 1 Hodgkin lymphoma. So the ratio is 4:1. So that's how common Hodgkin lymphoma is. However, in pediatric age group, it is a more common lymphoma. We all know it has a bimodal disease. Mostly it is a disease of young. It is also the second peak comes in around 50s, late 50s and early 60s. The key characteristic features of Hodgkin lymphoma are the contiguous spread of lymph node. While NHL spreads mainly through hematological route, Hodgkin lymphoma spread is more contiguous. So you will see the lymph node are in bunch in neck area and axilla. So they are more characteristic of Hodgkin lymphoma. This is a very old time finding, rubbery consistency, firm consistency. You know, if you ask me, they are all subjective description. It is not very common to find. If you see in India, if you sit in our clinic, you will find patient of Hodgkin lymphoma after COVID coming with large lymph node. They are no longer rubbery. They have become rock hard. They become hard because they were left untreated. So these are old classic description, but it is good to know that. Okay, so like NHL, HL is also classified into various subtypes. The two major subtypes that you must remember is classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma, which is better known as NLPHL. Right? Now, classical Hodgkin lymphoma has four subtypes. You can read. This is more of a pathology interest, although it has clinical implication and prognostic implication. Nodular sclerosing variety is the commonest lymphoma in India, and this is one variety which is more common in female patients than in male patients. By and large, epidemiologically, lymphoma is a disease of male individuals. Males are 2 times more likely to develop lymphoma than female patients. There is no logic behind it. It is some form of natural selection. However, this is one lymphoma which is more common in female patients. Staging and the workup is extremely similar to what we saw for DLBCL and NHL. You can just see those slides. How to treat Hodgkin lymphoma. Here, the prototype therapy is ABVD, and other principles are same. If it is early stage, you give 2 to 4 cycles of ABVD and give radiotherapy. If it is advanced stage, you give complete 6 cycles of radiotherapy of ABVD, and radiotherapy only if it is needed. There is some residual site, you give radiotherapy. ABVD, these are the acronym: adriamycin, bleomycin, vinblastine, and dacarbazine. And this is how these are the doses, how you give it. RCHOP and CHOP were given every 3 weeks after 21 days. ABVD, on the other hand, given after every 15 days. So you can see here, so it is given after every 15 days. One major difference is one cycle is divided in 2 parts, part A and part B. So you can see every cycle 2 has 2 parts, 3, 4, 5, and 6. So only when you have given 2 ABVD, it becomes one cycle. So therefore, if you are going to deliver 6 cycles of ABVD, you have to give it 12 times. So it is a common confusion. You must know that this is how you give ABVD. Whenever you are giving ABVD, it is because Hodgkin lymphoma is a disease of young. Be very aware about skin and pulmonary toxicity of bleomycin. Bleomycin can give rise to severe pulmonary interstitial lung disease, which can be fatal. With adriamycin and dacarbazine, you have to understand bone marrow toxicity is there. Cardiotoxicity is only with adriamycin, and dacarbazine is high hematogenic potential bone marrow toxicity, and it also has some bearing on fertility. Okay, so with this, the last slide, take home messages for lymphoma. Lymphoma is not a disease, but a cluster of malignancies of lymphoid system, and by far the most heterogeneous malignancy known to human beings. It can involve any organ of the body. In our country and other developing countries, tuberculosis is the greatest mimicker of lymphoma. If you sit in lymphoma clinic, you will be saddened and pained by seeing that how many patients receive ATT for a patient of lymphoma just plainly on clinical grounds without investigating them further. This is a harsh reality of medical practice in some parts, which is unfortunate in 2022. However, this is one must keep in mind. For example, tomorrow one of you may become nephrologist, hepatologist, gastro. My only request will be, if any patient who was started on empirical ATT is not responding within 4 weeks, then think lymphoma before you think of MDR tuberculosis. A lymphoma is by far more common than having MDR tuberculosis. So this is the point. The standard diagnosis and biopsy histopathology I have just discussed. Last line, if you treat DLBCL the way I have just shown you and patient respond to therapy, 60% cure can be achieved in DLBCL, which is the commonest lymphoma. If Hodgkin lymphoma is treated properly with ABVD, cure rate of 85% can be achieved. So treatment of lymphoma can be very, very rewarding, and therefore all the attempts must be made to diagnose these patients early, to provide them therapy, and to follow them diligently. The therapy of lymphoma is very cheap. Total cost of one cycle of CHOP chemotherapy is only 3,000 rupees or lesser. Rituximab has become very cheap. For one patient, one cycle dose is around 10,000 to 12,000 rupees. So in 15,000, you can get complete cycle of R-CHOP chemotherapy, which is a modern chemotherapy containing targeted therapy and everything which you hear fancy. And within 15,000, one cycle is complete. So this is an overview of lymphoma, which is a very large topic to be covered. But I hope you got the idea about what is the spectrum of lymphoma, what are the common subtypes, how is it growing in the world, and what are the main lines of therapies of lymphoma. So I think I finished well within time. So it is now open for any question or whatever you want to ask.